Good afternoon, everyone. Can everybody hear me in the back? I would like to thank Dr. Levine for the invitation to give this grand round. And my topic today about optimizing management for inflammatory bowel disease. I have no disclosure related to this topic. These are my objectives. We'll go over epidemiology, clinical and endoscopic presentation, current therapy for inflammatory bowel disease, optimization of therapy, and quality measures in the management. Let's go over the epidemiology. Molodoki et al. Conducted a big retrospective study for over 30 to 50 years, and for the first time included data from patients from Asia and Middle East. So the incidence of ulcerative colitis was 24.3 per 100,000 a year in Europe, 6.3 in Asia and Middle East, and 19.2 in North America. And again, that's the first study, to include data from Asia and Middle East. Prevalence was 505 per 100,000 a year, per 100,000 in Europe, and 249 per 100,000 in North America. What about Crohn's disease? Incidence 12.7 per 100,000 a year, 5 per 100,000 a year in Asia and Middle East, and 20.2 per 100,000 a year in North America. For the prevalence, 322 per 100,000 a year in Europe, and 319 in North America. And as you see, we don't have any data from Asia or Middle East as a prevalence because of lack of information. You have to know, out of this study, we also were able to know that incidence in men was higher for ulcerative colitis, while incidence in women were higher in Crohn's disease. The peak in the age of 30 and 40 for ulcerative colitis, and 20 and 30 for Crohn's disease. However, we have to know that there is another peak for old age patients around the age of 60 in Crohn's disease. What about clinical presentation? Ulcerative colitis is a disease of the colon, and mainly in the left colon. So what you expect: bloody diarrhea, urgency, tenesmus, and incontinence. These patients will have big problem with kind of distal colon, weight loss, fever, and up to 30% of the patient will have constipation. Why is that? Because they have severe inflammation in the rectum and left colon, and they don't want to go to the bathroom, as simple as it is. Extraintestinal manifestation can be present. What about Crohn's disease? They present with bloody diarrhea, abdominal pain, fever, weight loss. You can see in the pediatric age group, growth failure. You can see perianal disease, fistulizing disease, stricture, and also extraintestinal manifestation. What about endoscopy? It's kind of unique difference between UC and Crohn's disease. UC starts in the rectum and grow proximally to the right colon. So you will see the disease mainly involving the rectum and progress proximally. While in Crohn's disease, it can affect any area from the mouth to the anal canal. Concerning the spread of the inflammation, in the UC, it will be continuous. If you have the rectum involved, the whole rectum will be involved. While in Crohn's disease, you will see scap lesion, area involved tissue, area normal tissue. What about the depth? UC affect mucosa, submucosa, Crohn's disease, transmural, affect all layers. As a result, you will get stricture, fistulizing disease because it's penetrating disease. What we see when we scope the patient in addition to this, we see loss of vascularity, erythema, granularity. In Crohn's disease, we see more epiths, ulcers, cobblestone appearance. You have to remember there is a group of patients with UC, they will have a rectal sparing, especially patients with primary sclerosing cholangitis. That's kind of a study was done to see the distribution, anatomic distribution of UC. 46% proctitis, 17% left colon, 37% pancolitis. What about Crohn's disease? 33% small bowel only, 45% ileocolonic disease, and 20% colon only. This is a picture to tell you the difference between UC and Crohn's disease. As far as the picture go, you can see inflammation continuous involving all, the colon. Here, Crohn's disease, you have one wall with severe inflammation and ulcer, and you see this fold almost looks like normal. Picture is better, of course, when you do the scope and you see the whole area to differentiate between a skip lesion and continuous inflammation. Backwash ileitis, that's an entity that described mainly with ulcerative colitis, 10 to 20%. A lot of people, they call it spillover colonic inflammation over the TI. It happened only with pan-colonic disease. And you do the scope, you see inflammation throughout the colon. And when you go to the TI, you see some inflammation. However, endoscopy and biopsy confirm presence of ulcerative colitis. In those patients, you need to get small bowel imaging to exclude Crohn's disease. What about the natural history of Crohn's disease? Barnett et al. In 2011 conduct a study which gives us a very good idea about what is the natural history of Crohn's disease. This slide, very important, and it changed a lot of our thinking, because in the preclinical time even, you can see the patient will have a lot of inflammation. As months and years go, they start to develop inflammatory structure, fistulizing disease abscess, surgery, and then fibrotic structure. How this is helpful, I will talk about it more in my talk, but if you will hit the patient hard early on, you can prevent the consequences. Also out of this study, we came to know that what is the cumulative risk of structuring or penetrating disease in Crohn's disease. In 90 days, up to 19%, 1 year, 22%, 5 year, 34%, over 20 years, almost half of your patient will develop structure, fistula, or any kind of form of penetrating disease. Again, this confirms if you will treat the patient early, you will have a good result. So let's go to the medications that we use, or all the medication available out there for our use. We have 5-ASA or aminosalicylates, corticosteroids, antibiotics, immunomodulators, biologic, cyclosporin, methotrexate. What about aminosalicylates, 5-ASA? Is there any evidence that they are helpful out there in the data or in the research? So we have 3 groups. First group is pH dependent. As you swallow the medicine with a change of pH from acidic to alkaline, this helps to release the active substance of the treatment. And they have the acrylate-coated mesalamine and mainly affect ileocolonic area. What about time release? This one has ethyl cellulose encapsulated product, which as more time the capsule spends in the colon, you start to release the active substance. The last group depend on having as bond, which it gets broken by bacteria, and the bacteria cleaves this as bond and release the active substance. And those are the 3 groups of 5-ASA available in the market out there. So we have 2 different types of 5-ASA. We have the oral medicine we use, and we have the rectal medicine. The rectal one, we have enema, we have suppository, we have foam or gel. And there was a study conducted by SAFD to compare which is better. If we'll use oral medicine alone, foam or gel or enema, or all rectal components alone, or combination therapy. And you can see after 6 weeks, combination therapy, people who have used oral and rectal components, they have done better compare each agent or each component alone. So what evidence available out there helpful for our treatment? And you see 5-ASA is effective in induction and maintenance of remission for distal colon disease, not for pan-colonic. Distal colon and mild to moderate disease. The evidence we have, as I showed in the last slide, combination is better than a single agent. and not effective as a steroid-sparing agent. What does this mean? If you have a patient with ulcerative colitis, mild to moderate, he's on a steroid, and you give him 5-ASA and it works, 5-ASA is not going to act as a steroid-sparing agent. This means that you need to move on to another agent to help to get the patient in remission. And that's the goal. I will talk about it later. For Crohn's disease, no evidence to support the use of 5-ASA in Crohn's disease. Studies have shown 5-ASA is slightly better than placebo. However, it's not statistically different. And it's not statistically significant, and we don't use it anymore. Corticosteroids. So, based on the studies out there, what is the evidence we have for corticosteroids? This study was done by Fabian et al. Out of Mayo Clinic. It was done in 2001, and they did the same study for patients. It's a retrospective study, looked to the patient with ulcerative colitis and patient with Crohn's disease. And they studied the effect over 30 days and over 1 year. So over 30 days, 54% had complete remission, while 16% they didn't go into remission. 22% become steroid dependent, 31% prolonged response, 29% went for surgery. What are the two pieces of information or two pieces of evidence we got out of this study? A lot of people after 1 year require surgery. If you remember the slide I showed earlier, the people that they need surgery within the first year is less than 20% without any treatment. So those people require surgery more than even normal or more than the patient with disease without treatment. So higher incidence of surgery. And the other piece of information we get to know from this study is that it's a good therapy for induction. However, it has a very bad side effect profile. What about Crohn's disease? 58% went into complete remission within 30 days. However, 32% become steroid dependent at the end of 1 year, and almost 40% require surgery after the first year. Again, higher incidence of surgery and steroid dependent, and again, it can induce remission. What about budesonide? Budesonide is a corticosteroid but has a minimal systemic absorption. Why is that? Because of first pass metabolism. We have two forms of oral budesonide. We have pH release, which affects the ileum and right colon, and we have Budesonide MMX, which is a multi-matrix system that helps the budesonide to kind of involve or affect directly the colon only, and it has more topical effect. There is also rectal budesonide in a mouth form. So what evidence we have out there for budesonide? For Budesonide MMX, Sanborn et al. Conduct a study for mild to moderate ulcerative colitis and compare placebo with Budesonide MMX 9 milligram, 6 milligram, and Asacol. And the 9 milligram form was statistically significant compared to placebo and inducing clinical and endoscopic remission, and also inducing symptoms improvement. So we can get out of this study that Budesonide MMX is effective in induction of remission in patients with mild to moderate ulcerative colitis. What evidence we have for Crohn's disease? There was a study was done by Greenberg in 1994 and compared Budesonide with to placebo, 3 milligram, 9 milligram, 15 milligram, and again it was effective in inducing clinical remission. This is an interesting study. I put it here because some centers changed their way of practice based on this study. That's a study was performed by Farrell et al. In 2003, where they compared two groups of patients. Patients who are getting infliximab without any prior steroid prior to injection, and the other group of patients, they received a single dose of steroid prior to their infliximab injection. And they compare, or they looked at the presence of antibodies to infliximab. And there was big difference for the evidence or the presence of antibodies in patients who receive steroids compared to who didn't receive steroids. So what evidence we have for steroids? After all this, the evidence we have out there is that we need to minimize the use of steroids. Steroids are not good. They have a very bad safety profile. Budesonide may be helpful in patients with ulcerative colitis and to induce remission. We don't have any data about maintenance of remission of budesonide. However, there are studies, there are ongoing studies for this. And we use only corticosteroids nowadays as a bridge. What about methotrexate? Methotrexate, to be honest, it's underused in our GI community. However, our colleagues from rheumatology, they use it all the time for their diseases. However, the evidence we have out there for Crohn's disease, it can help to induce remission. However, it cannot be used alone. It has to be used with other medication like Biologic or whatever other medication you will use to induce remission, mainly for relapsing or refractory Crohn's disease, and for patients who cannot tolerate either Biologic or thiopurine. For ulcerative colitis, there is no evidence at this point. However, there are 2 European studies are going right now to study the evidence of, or if methotrexate can help with ulcerative colitis. The dose we use, 25 milligram IM or subcutaneous every week, in addition to folic acid. This followed by maintenance therapy. It can be used IM, sub-Q, or oral. And those patients should have CBC, liver function test, creatinine, albumin every, initially it should be at 2 weeks, 4 weeks, 8 weeks, and then every 2 to 3 months because of the to monitor for the side effect of the treatment. So what complication can we get with methotrexate? Liver disease. We can get cirrhosis, mainly for patients who have a picture of metabolic syndrome, obese patient, dyslipidemia, and hypertension. Those patients, even initially if they have normal, AST, ALT, other numbers of the liver, you need to monitor because they can develop cirrhosis. Alcoholism, also patient can develop cirrhosis. Renal insufficiency can lead to toxicity. Immunodeficiency can lead to infection, can worsen leukopenia and thrombocytopenia. For pregnancy, male and female, it can cause birth defects and teratogenicity. And most of the people now recommend the couples that they need to get pregnant, either a male or female, to stop the treatment at least 3 months prior to getting pregnant, and there is a process they have to go through to make sure they are not going to get any side effect of this. Cyclosporin. This drug has been out there and it has been studied for quite a bit of time. I'm going to go only for the evidence we have right now. The evidence that we use cyclosporin now is as a salvage therapy for patients with fulminant, severe fulminant colitis, mainly ulcerative colitis, and we use it as a bridge. It's a complicated medicine with difficult to control, and it has kind of bad safety profile. So initially we give it IV and then followed with oral treatment, but again we use it only as a salvage bridge together with hydrocortisone to induce remission before starting the other medication. No evidence to be effective in Crohn's disease based on the studies we have. Let's move on to the other group, thiopurines. Thiopurines, we have 2 types of medication, or 2 medication. We have either thiopurine and 6-mercaptopurine. Those are the 2 medicines that we use. What indication we have approved for? Maintenance of remission, steroid-sparing agent, reduce incidence of surgery, and treatment of fistula. As what can you see, it does not induce remission. So what is the metabolism we have? How does it work? So the azathioprine get metabolized to 6-MP, and using the enzyme xanthine oxidase, it gets into inactive component. Using another enzyme called TPMT, it gets to metabolize to 6-MMP, and then using HPRT, it gets to the 6-TGN. 6-TGN is active substance that work against the inflammation or against Crohn's disease and ulcerative colitis. This is the active component. So TPMT enzyme, it's a very key enzyme in this process. And as we came to know the enzyme and what can lead to, not everybody has the same enzyme activity between the normal population. 89%, they have normal or high activity. And those groups, they have a wild type of the gene or this enzyme. 11%, they have intermediate activity, and they have heterozygote gene. 0.3%, they have very low or no activity. And those group of patients, they have homozygote gene, and those are, or those patients that we worry about all the time. It's now a standard of care to check TPMT before starting azathioprine or 6-MP. And you have to check, not you have to, but many times we check 6-TG, 6-MMP to see if the medicine is working or not, especially if you start treating the patient and either you don't see an effect or the patient is developing side effect of the medicine. And the adequate dosing to want to make sure that your patient is getting the right dose of this treatment, 6-TG should be more than 235 and 6-MMP should be less than 5,700. What about the dose of thiopurine we use? For patient with normal and high activity, that's why we need to check the enzyme for every patient before we start. For azathioprine, we use 2 to 3 milligram per kilogram. For 6-MP, we use 1 to 1.5 milligram per kilogram. For people with intermediate activity, which is 11% of the population, we use half of this dose. Or as many of us do, we start the patient on a low dose, 50 milligram, and then in those patients, we need to check the 6-TG and 6-MMP metabolites to see is the patient getting the right dose, is the patient overdosed or underdosed. If the patient has no activity, no enzyme activity for TPMT, you need to switch to another medicine. So is there any evidence that thiopurine help or to maintain remission for Crohn's disease? There was a study, 2 studies actually. One was Candy et al. Was done in adult, which showed that thiopurine patients have better remission rates compared to placebo. The other piece of information that we got to know from this study is that thiopurine start working after 3 months. That's why the medicine only used for maintenance of remission, not to induce remission, because it works after 3 months. Markowitz et al. Conduct the same study, but using 6-MP in children. And again, you can see that people with 6-MP, they are doing better, or children who received 6-MP, they are doing better compared children who only received placebo or steroid. What about thiopurines and incidence of surgery? This is actually one of the landmark study was conducted out of UK. Chateau et al. Looked retrospectively into all patients out of the data collection in UK. And he looked to the data between 1989 and 2005. And he split those patients into 3 groups. Group A, 89-93, Group B, 94-99, Group C between 2000 2005. And you can see Group C between 2000 and 2005. This is a group that they received thiopurine the most compared to the first group. And it's not surprisingly, because we start to know more about these patients. So what is the incidence of surgery? So Group A, who received more thiopurine, they have less incidence of surgery compared to Group C, who received less thiopurine. So thiopurine can prevent against surgery in patient with inflammatory bowel disease as long as they are taking the right medicine and the right dose. Let's move on to the biologic therapy. That's what we call in our GI community revolution of our treatment and change the way of thinking. First biologic therapy was started to be used in 1998, so now we have 16 years of data, and the first component we used was infliximab. So what were the goals for treatment and what are the goals nowadays? In the past, our goals was to improve symptoms to induce partial response or to induce clinical remission, what we call complete response, and to avoid steroids. Nowadays, in 2015, our goals is to induce and maintain deep remission, give a better quality of life, induce complete mucosal healing, prevent surgery, minimize hospitalization, and treatment of fistula. You can see the difference between these goals and these goals. Big difference. So what biologic therapy we have? The one we use now, anti-TNF group, infliximab, adalimumab, satralizumab, golimumab, and anti-integrin group, natalizumab, and the latest addition is vedolizumab. That's kind of what is the component of each biologic. The infliximab has 75% human, 25% murine or mouse component. Adalimumab is monoclonal human antibody. Certolizumab is monoclonal human antibody with a Fab fragment, what we call pegylated humanized one. So the good part about these medications that you give it through injection, either IV or sub-Q, and the patient doesn't have to take the medication every day. He takes the medication at a certain frequency. For example, infliximab we use for Crohn's ulcerative colitis. We use induction dose at 0.26, and then every 8 weeks we can decrease the duration if patient needs to. But many patients, they just get the medicine every 8 weeks. So it's not really bad. Adalimumab and satralizumab, they can give themselves injection at home, sub-Q, so they don't have even to come and follow up. What about golimumab? Golimumab is recently approved for moderate to severe ulcerative colitis only. It does not cover Crohn's disease. And again, it has induction dose, 200 milligram, and then maintenance dose afterwards. You don't have to memorize these doses. What are the adverse events of the anti-TNF out there? Immunogenicity is one of the more common problems that we see. There are two types of immunogenicity. There is acute and there is a delayed type. The good part, majority of these reactions, they are not immunoglobulin E mediated, and they are not anaphylactic reaction. So that's what we get to tell our patient. Yes, there is immunogenicity to the drug. It can cause some reaction, but most of the time, not all the time, they are not immunoglobulin E mediated. What about heart failure? There were multiple studies done, especially with infliximab, and people who received infliximab 10 milligram per kilogram, they had very bad outcome. I'm talking about patients with New York Heart classification 3 and 4, and even they have a higher mortality. So now in our practice, any patient with heart failure, we get our cardiology colleagues on board, we get echo, and the maximum dose we use 5 milligram per kilogram. Patients can develop demyelinating diseases, multiple sclerosis, optic neuritis, others. Infection is a major concern, and one of the common things we use can get bacterial, fungal, viral, tuberculosis, If the patient has active TB, we don't use the medicine. However, if they have a latent one, we can start treatment and then start anti-TNF. It's not clear about the timing. When you start the anti-TNF, some people, they recommend to start after a short period of time. Some people, they recommend to complete treatment before you start anti-TNF. The data is controversial out there. Hepatotoxicity, it's not common. However, we see it every now and then, more hepatocellular compared to cholestatic. It has autoimmune characteristic, and there are rare cases for hepatic failure. And those are kind of few case reports out there. Also, there are few case reports about requiring liver transplantation. Neutropenia, usually mild. You can get cutaneous reaction, psoriasis, injection site reaction, infection, or eczema. What about cancer risk with anti-TNF? Risk of lymphoma is a major problem. However, when you look to overall risk, is not that bad compared to the general population. And if you will talk to your patient and discuss with him the actual risk compared to the side effect he can get from not getting treated, the benefits outweigh the risk in this situation. So when I sit down and talk to my patient, I tell them what is the risk in normal population. So the risk in normal population is 2 in 10,000 in this age group that we see. With thiopurine is 4 in 10,000. With combination therapy is 6 in 10,000. The most worrisome is Hepatosplenic T-Cell Lymphoma, which is almost universally fatal. Between 1996 to 2011, we have 36 cases detected. 16 patients were using thiopurine alone as monotherapy, and 20 patients were using thiopurine plus anti-TNF. Some experts now, they kind of, instead of using combination therapy with thiopurine, they use anti-TNF or anti-integrin with methotrexate, especially in the young age population, young male. And as you see here, it's common in male, young in age, especially less than 35 years of old. What about other cancer risk? Non-melanoma skin cancer, more commonly or mainly with thiopurine. Combination therapy, people can get non-melanoma skin cancer, but mainly with the thiopurine part. You will get squamous cell carcinoma more than basal cell carcinoma. There are, based on the retrospective data we have out there, there is a little bit of increased incidence of melanoma in people who are receiving anti-TNF. However, the actual numbers are not clear. What about integrin inhibitors? We have two groups, alpha-4 beta-1 integrin, which is the VCAM receptor, mainly in the CNS, and we have the alpha-4 beta-7, which is the MADCAM receptors in the GIT. The first drug we had from this, or we have from this, is natalizumab, which came into use late 2007, early 2008. Natalizumab, or Tesapri, kind of inhibit both alpha-4 beta-1 and alpha-4 beta-7. So inhibit the receptor in CNS. And I will tell you guys more why this is important. And then the newer additions that came in May of last year, vedolizumab, and it preferentially prevent alpha-4 beta-7, which affect preferentially the GIT. So again, another cartoon to tell you about alpha-4 integrins, alpha-4 beta-1, VCAM, alpha-4 beta-7, MADCAM, and that's how it works within the blood vessels. And with those alpha-4 integrins, we kind of moved on from using anti-TNF that they work at the tissue level to medications that they work at the blood vessel or vasculature level rather than the tissue. What about Tisabri? It's actually a very good drug, It's effective against induction and maintenance of remission, moderate to severe Crohn's disease. It works to induce induction, but it doesn't require an induction dose. It's mainly one dose you give, and you give it continuous every 4 weeks. Here is the main problem. PML, progressive multifocal leucoencephalopathy. That's a major concern. Out of all the cases we have for Crohn's disease, only one case was found. Most of the cases coming out of the demyelinating diseases literature. However, there are pretty major restriction in use of this because PML is fatal. You cannot use any concomitant immunosuppressant. And concerning the GC virus, which cause or which lead to the PML, if the patient, you check the anti-GC virus status, if the patient is negative or positive. Negative patient, the risk for those patients even being negative, the risk is less than 0.1 in 1,000. And in those patients, you can start treatment, but you need to check GC virus every 6 to 12 months. If the patient turns positive, you need to stop the medication. If the patient has a positive test or positive GC virus antibody, the risk in first 2 years is 2 in 1,000. After 2 years is 11 in 1,000. And in those people, we recommend to use another agent. In this group, if the patient is not responding to the treatment, you need to stop the medication because you don't want to get the side effect of the medicine, which is a PML, and the patient is not even responding or not getting any benefit out of this treatment. What about the vedolizumab or Entyvio? That's a newer rendition, as what I said. It has been, it was approved in May of 2014 for ulcerative colitis, Crohn's disease, moderate to severe. It can induce and maintain remission. So far, most of the people agree that we use vedolizumab when patients fail anti-TNF. We don't use it as a first treatment. However, there is big debate about this, but as of this point, we only use vedolizumab if the patient fail other anti-TNF and combination therapy. So, with all this said about all the information, all the medication, how we can optimize our treatment? Use top-down approach, early diagnosis. You need to identify who's high-risk patient between the patient groups that we see and factors that can influence or may influence biologic therapy. Targets of our treatment is deep remission and mucosal healing. I said that's the new goal now. Use combination therapy instead of monotherapy, and you need to monitor your patient. This patient has a chronic disease like hypertension, like diabetes. It's not like you'll give the patient treatment and let him go home and see him in a couple of years. And there is in the future, as we are gastroenterologists, we may be, or proactively, we may be able to have a therapy plan which is different for every patient compared to the whole group of patients. Top-down approach, multiple studies done. Now we use any patient with moderate to severe disease, we use biologic and immunomodulator. Corticosteroid only as a bridge, antibiotic only if they have pouchitis or fistulizing disease, 5-ASA only in mild to moderate ulcerative proctitis. So mainly we had the combination therapy. So I said early diagnosis. Is there any data out there? This was a study conducted for cetralizumab, which was the same study done for other medication. And you can see patients who start treatment less than 1 year from diagnosis, they have done better compared to patients who started treatment more than 5 years of the diagnosis. Statistically significant. So early diagnosis and early treatment make a difference. What does this mean? If you have a patient with symptoms, patient with any chronic diarrhea that you tried to handle at one time, it didn't work, you need to refer the patient to a gastroenterologist and to start think about inflammatory bowel disease. Who is high risk in this age group or in our inflammatory bowel disease patients? And why this is important? I will give you a scenario that happened with me personally in my clinic. I get a patient, 37 years old of age, a month ago. He had symptoms for almost a year. His primary care physician treated him as gastroenteritis with antibiotic 4 or 5 times. I scope him and he has severe small bowel stricturing, penetrating disease. We tried to start, biologic agent and combination therapy. However, he developed fibrotic stricture within just a short time, and he required surgery because he had a mechanical obstruction. The question from this patient, do I need 2 medications or I can start only 1 medicine? And his age was 37, so the age less than 40. One factor, he had an LEL disease, small bowel disease, and he was a smoker. So you have 3 out of the 6 criteria, which is, very high risk. So in this patient, you need to tell him clearly, you need to be on combination therapy because you are a high-risk patient. Patient also who have used corticosteroids in the past, fistulizing disease and perianal disease. What are factors that may influence biologic therapy? Sometimes we see those patients in our clinic, they are on the right medicine, but the medicine is not working as it's supposed to be. Anti-drug antibodies. This kind of a lecture by its own, but I'm not gonna talk about it in details. But people during the course of treatment can develop antibodies to the medication. It can decrease the drug concentration, increase the drug clearance. If you will use immunosuppressant in the combination therapy, studies have shown that people in combination therapy, they do better than monotherapy because it reduces the development of antibodies. So that's another reason to use combination therapy because it minimizes the development of antibodies and it increases drug concentration and increase the drug efficacy. What else? Low serum albumin. We see this a lot during our inpatient service. Those patients, they have higher drug clearance. Patient with high CRP or high baseline TNF, those also have a higher drug clearance. Obese patient, they clear the drug more often compared to the thin patient, and male patients, they have a higher clearance for the medication. What about combination therapy? I think SONIC trial and SUCCESS trial, they kind of confirm what we have been doing and what we are thinking about those medication. SONIC trial studied the effect of combination therapy, infliximab and thiopurine, in comparing to infliximab alone and azathioprine alone. And combination therapy, it has better clinical response, endoscopic remission, and steroid-sparing agents. And this paragraph for mucosal healing, or this picture for mucosal healing. What about UC? SUCCESS trial was done, the same, kind of study, but was done for UC patients. If you look to graph A and B to assess clinical response and mucosal healing, and people with combination therapy, they have done better compared to a single agent. The last part of my topic, in the last few minutes we'll talk about quality improvement in inflammatory bowel disease. What do we mean by quality improvement? Cory Siegle put a good definition for this, and I quote here: to ensure the best new research and ideas do not get behind in the journals, but get applied in a cost-effective manner equally to all patients. So we'll provide this care, or the best of care we have, to every patient equally. Uniform, equal, high level of care to all our patients. Even down the road, we expect that our reimbursement will be affected by our quality of care through the insurance company. However, that's not the first goal. The first goal is to provide the best of care to your patient. And at the end, something you can measure, something that we can all talk about as gastroenterologists, primary care, other subspecialties. Subspecialty we can talk about and we measure if we are doing better or if we are not. What quality measure we should focus at during this process? Documentation. So we should, in our documentation, you should provide what kind of chronic disease this patient have, or this patient has, sorry. For all, if you will see all our notes for inflammatory bowel disease, we need to document what disease the patient has, severity of the disease, time of the diagnosis, has the patient had surgery before or not, the extent of the disease, current treatment, prior surgery. It's a long list, but that's how we can make a difference, because a year or 2 years from now, if another doctor is looking to this note, he can tell what type of chronic disease or what is the course of disease the patient has. I said earlier, that's a chronic disease, like diabetes, like hypertension, like cancer. It's a chronic disease, it's not one-time treatment. Current treatment is the patient any steroid-sparing treatment in addition to the other things. For thiopurine, you need to document what was the TPMT level. Smoking, especially with Crohn's disease patient, you need to document that you have worked with your patient to quit smoking. Nutrition, that's very important. Those patients can get hypocalcemia, low vitamin D, B12, especially with Crohn's disease patients who have ileal disease or who underwent ileal resection. Also nowadays, as a standard of care, we get iron profile in all of these patients. And if the patient is iron deficient, they need replacement. What about prevention? Vaccines. You need to make sure that the patient is up to date on the vaccines. There are live vaccines and kill vaccines, and that's a lecture by itself, but you need to make sure your patient is up to date. Bone scan, those patients, we normally, what I do in my practice, we order a bone scan at the baseline, and then it depends on the result. If it's normal, you can do it every 2 to 3 years. If it's abnormal, you can do it every 1 to 2 years. Colorectal cancer screening, the available data now, screening every 1 to 2 years, except for patients with primary sclerosing cholangitis. We do it every year because they have a higher risk of colon cancer. However, there is kind of a study coming out of UK. We don't have the whole result yet. It may change this kind of screening, but we don't have this applied in the US at this point. What we do during hospitalization of the patient comes to the ER, you need to check those patients for Clostridium difficile, and you need to start the patient on prophylaxis for thromboembolism. Those patients, they have a higher incidence of thromboembolism compared to the normal population, especially during hospitalization. Skin cancer, for people who are receiving thiopurine, they should get an annual skin cancer through their primary care physician or dermatologist to screen for non-melanoma skin cancer. And thank you. Questions?